Hi, I'm Lindsay Maybray, and today I'm going to be talking to you about prone positioning. Indication for prone positioning are when patient with ARDS are mechanically ventilated and they have optimized ventilation with adequate PEEP, an inverse I to E ratio, and the patient has been monitored for effects. Despite optimizing ventilation, there are things that indicate putting a patient in prone position, such as a PaO2 to FiO2 ratio of 150 or less, a PEEP of 7.5 or more centimeters of water pressure, pulmonary artery occlusion pressure of greater than 18, or no clinical signs of left heart failure, bilateral infiltrates on an anterior posterior chest x-ray. There are exclusion criteria to putting a patient in prone. If the patient is a do not resuscitate or a DNR, if they have asthma, if they have had a head injury, raised intracranial pressure, if the patient experienced seizures, has a spinal injury, osteoporosis, recent abdominal surgery, recent stoma, if the patient is pregnant, at least if they're in the second to third trimester, if they have an open chest, because it wouldn't be good to lay someone down on their stomach if they have on their stomach and chest if they have an open chest wound, an intra-aortic balloon pump, recent cardiothoracic surgery, recent cardiopulmonary arrest, a new tracheostomy that is less than 24 hours old, recent pelvic or chest fractures, because that would just hurt the patient to put them on their stomachs in. Some more exclusion criteria: if they have acute bleeding, increased intraocular pressure, hemodynamic instability, a MAP less than 60 millimeters of mercury, or a weight greater than 135 kilogram, or kyphosis. There are preterm considerations. If the patient is a suitable candidate for the use of prone position, the following measures should be undertaken. Pressures area risk calculated and the assessment made for use of specialized mattresses, eye care. Importantly, clean and lubricate with simple eye ointment. Maintain eye closure using a special tape, so that way you don't accidentally scratch the cornea or cause any trauma to the eye that's unneeded or unnecessary or accidental. Mouth care, also suction all the excessive fluid from the mouth and oropharynx. Insert a closed suction equipment, date and change as per product guidelines. Check all central venous and arterial access sites for inflammation, and also if they need to be changed. That would be more of a nurse thing than a respiratory therapist. Wound dressing require on anterior aspect of the body to be performed before turning. Also, this is a big important one. Ensure the ET tube or endotracheal tube and tracheostomy tapes are checked to ensure that they are secure. You have to make sure your airway is secure. That is important. Tracheostomy care, dressing, changing according to the guidelines. Ensure chest x-ray is taken if it's been ordered. The patient should not be disconnected from the ventilator during the procedure. Disconnect them, they can't breathe, they're already having issues because they're in the prone position. They more than likely have ARDS and they're trying to get them to oxygenate and ventilate better. Document grade of intubation and the length of the ET tube at the teeth. So that's all it's saying is check the position before you turn them, make sure you know where it's at. Make sure you didn't pull it out when you turned them, so if you did, if that's a little bit. Assess the patient's level of sedation. Aspirate nasogastric feed. Stop nasogastric feed for the duration of the turn. Check the placement of the tube before recommencing the feeds. Ensure there is sufficient length of the IV tubing available, because you don't want to flip them and then you don't have enough IV tubing and it pops out. Patient would not like that. Placing a patient in the prone position. Placing a patient in the prone position requires significant effort and has serious risks. Close attention to lines, drains, and airways is critical, as obsessive attention to pressure points, padded, and prevention of ulcer. Make sure an doctor is in the room. Identify the turn leader. That's usually the patient's primary nurse. Respiratory therapist should be at the head of the bed, responsible for the ET tube. Minimum 2 staff each side of the bed. Tuck arms under the patient. Place a pulse oximeter probe on a limb not being turned under the patient. Place 2 pillows on the patient's chest. That's to help with sores, so they don't get pressure sores. Place a flat sheet on top of the pillows. Slide the patient to the edge of the bed away from the ventilator. Check ET tube lines and other tubes. Rotate the patient slowly. Turn the patient towards the vent until the patient is in prone. We're going to check the ET tube lines, assess lines and other tubes for dislodgement, kinks, or air entry. Position arms in a modified swimming crawl. Face is in the direction of the raised arm. Shoulder is dropped and elbow is below axilla, and other arm is at the side, palm facing up. Ensure pillows are under the shins, because that's a good area where they get a lot of pressure sores, and are off of the bed. Reattach any disconnected lines or cables. Effectiveness of prone assessment. No oxygen saturation, SpO2, in the supine position prior to turning the patient into the prone position. Arterial blood gas samples to be taken before placing the patient in the prone position, and the PaO2 to the FiO2, which is the oxygen index calculation. Once in the prone position, oxygen is monitored using the SpO2. If this deteriorates below the supine values for more than 10 minutes, turn the patient back to supine. The goal is to try to get the patient to oxygenate better, so if they're deteriorating, we don't want that. If the patient responds to the prone position by increasing the SpO2 beyond that achieved in the supine position, take an arterial blood gas after 1 hour and calculate the oxygen index. Thereafter, monitoring the oxygenation, use the SpO2 and perform arterial blood gases as required. An acceptable range of SpO2 and PaO2 should be established for the individual patient. 1 hour prior to turning back to supine position, take an arterial blood gas and calculate the oxygen index. Once back in the supine position, take an arterial blood gas and calculate the oxygen index. If the patient's oxygen status deteriorates to less than 150 in the supine position, return the patient back to prone. Preventing skin breakdown, pillows or foam pads may be placed under the upper chest and lower abdomen to avoid pressure sores. Care should be taken to allow the shoulders to fall slightly. This avoids overdistension of the anterior capsule of the shoulder joint and allows arm position to be more freely modified. The prone position itself may be modified as followed, but a 3/4 prone facing right or a 3/4 prone facing left, utilizing pillows to support the side to be lifted. The arm and legs on the side towards which the patient is facing may be flexed. The head and neck be aware of the patient's natural position. For example, they may have a fixed kyphosis or a condition such as rheumatoid arthritis or cervical spondylosis. Options: the head of the bed may be elevated to try to minimize facial oedema, and that's just the soft tissues engorging with fluid in the face. Excuse me. In principle, the head should be placed in such a position that the neck is not extended and the head is supported by the mattress alone. If the use of pads for the head to be supported is considered, this must be discussed with a physiotherapist prior to placement. Passive movement and limb positions. It is known that the stimulation for soft tissues deterioration is lack of movement. Muscles also become shorter and stiffer, leading to impairment function. If the joints are difficult to move, forceful movement may cause micro tears in the muscles and other soft tissue structures around the joints. Torn fibers will bleed, which may result in calcification. This forms a heterotopic ossification. Produces further loss of mobility, making movement extremely painful. So otherwise, if the limb does not move, don't force it. You're going to hurt your patient. Conversely, overstretch of soft tissues may also lead to symptoms resulting from adverse neutral tension and damage to connective tissue. Thus, it is important to maintain soft tissue length and mobility with a normal range of movement and a normal resting posture. There is no literature to suggest on how often passive movement should be performed. Patients should be changed or how often the limb should be moved. That's what I just said. There's no literature that supports that. Some intensive care units, what I found was they like to perform that about every 2 to 4 hours to prevent muscle stiffening, and also helps prevent sores, and passive movement is a good thing. The upper limbs, if neutral tissue is maintained in a stretched position for a prolonged period, Adverse effects may result. Therefore, the positions of the shoulder girdle joint and arms need to be found, which avoid stretching the brachial plexus. Options: both shoulders should be abducted with elbows flexed, maintaining some protraction of the shoulder girdle and degree of flexation at the shoulder joints. One arm parallel to the body and as the other is towards the lower limb. Care should be taken to avoid pressure on the knees, over distension of soft tissues of the anterior aspects of the ankle joints, and shortening of the Achilles tendon. And this is my son Oliver. He didn't want to be in the video, but he wanted to be my person who demonstrated the prone position. So this is Oliver doing a good job, and I took a picture of him.